third generation stents which have got biodegradable polymer. So what happens in high bleeding risk patients when you need to stop blood thinners for non-cardiac surgeries? Now we have some stents that you can stop blood thinner even within a month. So, like some patient who has got dengue fever, when your platelets go down, so there are few stents now. One stent from US hospital company, Synergy, then we have master depth trial or multi-master stents. Now, you can actually stop blood thinner within 1 month. There is no need for dual antiplatelets. We used to give aspirin plus clopidogrel or any other second antiplatelet. Now you can stop that. And the patient can undergo urgent non-cardiac surgery. Better to go for 3 months or 6 months of dual antiplatelets. Now, when I can share one example. I had one patient in my hospital who actually came with thrombocytopenia after stenting. So we stopped his blood thinners within a week of stenting, and there was no actually bleeding, no stent thrombosis. So that is how actually new stents they have made a difference. Not working. Here, this thing here. Amazing technology. So, this was stenting. We used to put stent after breaking the clot, and initially bare metal stenting, then drug-eluting stenting. Drug-eluting stents have put it actually brought down the stenosis rate from 40% to 5 to 10%. Stent thrombosis rate now with newer generation of stent is only 0.2%, 0.5%. So that is how the newer generation stent they have made a difference. This is 3 generation of stents. Very small, thinner stud stents, very easily deliverable. You can put it through your arm arteries. Very, very great outcomes with those results. This was the stent trial which I was just mentioning, that you can stop blood thinners. So other important innovation is imaging of coronary stenosis. So these are the tools which we use in our cath labs, like the newer things are IVUS, intravascular ultrasound, and one is OCT. So these are actually newer techniques. So what we do, we actually image the artery from inside first. Before putting a stent, before blocking, breaking that clot, we actually do an imaging first. Because what is seen by a naked eye, it is just a perception. So with angiography, what you see is not always what you get. So you see here, this is a perception here. And it looks like a normal artery. But when you do IVUS, you see it is just, you get to see a lot of plugs. This is plug, but here angiography is normal. So that is how imaging makes a difference. And coronary angiography, whether you take 8 views or 9 views or 10 views, it is just a 2-dimensional angiography. We are taking also 1 views, but IVUS has made a difference. And how imaging makes a difference? Because there is a lot of limitations with angiography. It is 2-dimensional versus 360-degree topographical image and IVUS source. And basically, it depends on patient size. If patient is obese, you will miss some blood. Or it can't tell us about the calcium volume. The biggest enemy for interventional cardiology is calcium. So if you are stuck up with calcium, your stent will not get deployed properly, and the patient will come back within 3 months or 6 months. Or recurrent angina, or maybe stent thrombosis also. That increases morbidity and mortality. So, which is very important that when we put stent, outcomes should be very good. And there are some anatomical limitations, like in left mid disease, you can't actually judge the area, judge the plaque, calcium. Then osteal disease, you can miss osteal disease, where the artery starts, like osteoartery disease, bifurcation disease, complex lesions, you need imaging. And that was the point of purpose of telling you that we are getting lots of complex patients. When even the younger patient, when we do angiography, we see diffuse disease, complex disease, not single focal disease, very rare. So now complexities have also actually increased. That is why this is very important. So this you can see this looks like a focal cholesterol block, and this is angiographically. But when we do IVUS, we see diffuse disease. So it matters that where you put the stent. This is a simple ultrasound principle. It's a small transducer over the tip of the catheter. We take it inside the artery, coronary artery, before putting the stent or before ballooning it, and you see the structure of plaque. So when we this image actually makes it clear. You see here, this appears normal, the lesion appears normal, but once you do IVAS, you see. So this was the study actually, when they did IVAS of normal healthy coronary angiography reading, but they found around 50% block, average 50% block in most of the arteries. That is how the IVAS makes a difference, and it just adds a little cost to that simple angioplasty procedure. This is OCD. It gives us the exact picture of plaque. How much is fibrosis, how much is clot, how much is cholesterol, and the treatment depends on that. If some plaque is unstable, that can get ruptured because myocardial infarction. What was the etiology of myocardial infarction in normal coronaries, which is what? Vinoka. Myocardial infarction in normal coronaries. It can tell us the etiology. So this is how we make a calcium assessment, and we can choose our tools, how to break that calcium and put stent. The other interventional procedures are FFR. We use a lot of FFR in our lab. So it's a simple 10-minute job. You can actually assess whenever the lesion is intermediate, like 50 to 70% block. You can do FFR. You can measure pressure before the block and distal to the block. So if the gradient is less than 0.8, then you need to stent it. Otherwise, you can leave that medicine on medicines. Then outcomes are actually equivalent versus medical versus interventional. Other thing which we are now doing is drug-coated balloon. It is called matter-less angioplasty. No stents. Only one balloon coated with drug that will deliver the drug on the block, and the block actually gradually reduces, and the artery gets positively remodeled. Once you do angiography after 3 months or 6 months, you find a normal, healthy-looking artery after this DCB, and there is no need for any metal. No, now we are doing drug-coated balloon. I will show you one example. Then we have simple non-surgical mitral valve repair. In those patients, it is called mitral clip. In those patients who have got high surgical risk, you can't open the chest because the chest lungs are bad. Then we can just put a clip through femoral vein. It is just 2 hours procedure, 1 hour procedure, and patient goes home the next day. No need to cut. It is called mitral clip for severe mitral regurgitation. Then we have percutaneous valve repair, replacement for aortic valve, like aortic stenosis. It is called TAVR. We can do through femoral artery. It is just 1 hour procedure and 2 days stay, no cut. In those patients who have got moderate to high risk of open heart surgery for aortic valve replacement. Then we have bicable valves. We are doing bicable valves. So when any patient who comes with congestive heart failure, right heart failure, and he has got severe tricuspid regurgitation, lot of hepatomegaly, anasarca, gastropathy because of PR. Patient is not able to eat anything, and drugs are not working. You can't do a surgical operation. It's not bicable. So what you put a valve in IVC, you put a valve in SVC, the fluid, the volume overload is into the RIV. It doesn't go beyond. There is no regurgitation. So that is how you can reduce those congestive symptoms in TR patients. It is called bicable valve implantation. In my country, it costs around 7 to 8 lakhs. I know. But just 1 hour job. Then you have calcium cutting tools for putting stents, which is called orbital. Now there is a new balloon called intravascular lithotripsy. Like we have lithotripsy for renal stone, kidney stone, we have now lithotripsy balloon for coronary stones. So when you do a balloon, after ballooning it, you use a balloon called IVL balloon. It gives shockwave therapy. So it disperses calcium, then you can put stent after ballooning. It's a simple procedure, very, very safe procedure. And our government has approved it. It is costly, it costs around 2.5 lakhs, but the government has approved it. This means that actually it makes a difference to our intervention things and outcomes. Rather than calling patient again and again after 3 months, 6 months with re-blockages, it is better to put an effective stent which has got a good large diameter, like a normal artery. Then we have now laser for diffuse disease. So what does laser do? Laser is like any other laser. It just ablates all atheroma, all calcium, all cholesterol. It just goes down into the artery. Any small artery, diffuse diseases, it can open any block. No need to put stent. Do a laser, put DCB, coated balloons, patient is done with the intervention. And you repeat your angiography. It is meant for those frail, diffuse disease patients or any patient who doesn't want surgery or any stent. Then laser is intended. Then we have a penumbra device for deep vein thrombosis. When oral anticoagulation is contraindicated, we get a lot of DVT patients, obese patients, post-surgical, post-pregnancy. We have a lot of DVT cases. this is a device which can remove clot from femoral vein. You go from one femoral to other femoral, it is a suction device. It can